எல்லா கேன்சர் ட்ரீட்மெண்ட்ஸ்க்குமே சர்ஜரி அப்படிங்கிறது ஒரு தேவையா? பேசிக்கலி என்ன டிஃப்ரென்ஸ் ரெண்டு ஆன்காலஜிஸ்ட்டுக்குள்ள எப்போ ஒரு சர்ஜரி அப்படிங்கிறது தேவைப்படுது?
Most of the cancers, it is not that they go to medical oncologist initially. It depends on the cancer type. For example,
ஆன்காலஜிஸ்ட்லேயே ஒரு 2 பேர் இருக்காங்க அப்படின்னா, நான் ஒரு நார்மல் பேஷண்ட்டில் இருக்கேன்னு வைங்களேன். இப்போ இந்த பிரச்சனைக்கு இவர்கிட்ட போகணுங்கிறதே ஒரு இனிஷியல் ஒரு கன்ஃபியூஷன் மாதிரி இருக்காது. ஸோ ஹவ் டு பீப்புள் ஐடென்டிஃபை லைக் இந்த ப்ராப்ளம்க்கு நம்ம இவங்க கிட்ட போகலாம் அப்படின்னு?
actually there are three people, medical, surgical and radiation
oncologist.
Any person who is well experienced or well versed in seeing oncology patients, they can go to them. Oncology practice is a group practice. So me, medical oncologist, radiation oncologist, it is all who we work as a team. So whatever is happening to anyone, we will get to know.
இன்னும் அந்த கேன்சர்ஸ்க்கு நம்ம ஃபுல் பிரஸ்ட்டை தான் ரிமூவ் பண்ணுறோமா, இல்லை அதில் ஏதாவது ப்ரிசிஷனான சர்ஜரிஸ் இருக்கா?
First treatment was to remove the entire breast and axillary lymph node, skin over the breast. That was Halstadian mastectomy, that is called. It's a very morbid procedure. They'll remove all the muscles and all. Coming to now, we don't remove the entire breast. We remove only the tumor and a little bit of...
பெண்களுக்கு வந்து பிரெஸ்ட் கேன்சரில் அந்த சர்ஜரின்றது காமன் மாதிரி, ஆண்களுக்கு வந்து ப்ராஸ்டேட் அப்படிங்கிற விஷயம் காமனாக இருக்குது 40+ அப்படின்னு. அதில் இப்போ என்ன சர்ஜரி அட்வான்ஸ்மெண்ட்ஸ் இருக்குன்றோம்?
Now with the latest robotic and laparoscopic surgeries, what they are able to do is they are able to preserve the nerves which help in passing urine after the surgery, at the same time maintaining sexual health.
லைக் எனக்கு சர்ஜரி வேணாம், இப்போ நம்ம சொல்லுவோம் இல்லையா, எனக்கு ஊசி வேணாம் மருந்து கொடுங்கன்ற மாதிரி நம்ம இந்த கேன்சர் ட்ரீட்மெண்ட்டில் கேட்குற மாதிரி இருக்கா என்ன?
If other alternative treatment is having the same cure as surgery, then we give the option to them.
Okay.
But there are certain cancer types where we cannot avoid surgery. As we go on day by day, the cancers in young people are increasing, especially rectal.
Is it true, doctor? Like உண்மையிலேயே வந்து இன்க்ரீஸ் ஆகுதா, இல்லை அதை சும்மா பயன்படுத்துகிற மாதிரி சொல்லுங்கள்?
See, there are two reasons why it is increasing. One is
நம்ம ஒரு ஆப்ரேஷன்ஸ் பண்ணுறோன்னா அதுக்கப்புறம் தே லூஸ் தர் appetite, தே லூஸ் தர் வெயிட், அவங்களால ரெகுலர் ஃபுட்ஸ் எடுத்துக்க முடியாது அப்படிங்கிற ஒரு ட்ரெடிஷ்னல் மெத்தட் இருந்தது. இப்போ இருக்கிற அட்வான்ஸ்மெண்ட் மெத்தட் என்ன அந்த மாதிரி தான் வச்சுருக்குமா, இல்லை நீங்கள் சொன்ன மாதிரி என்னோட பேக் டு அந்த குவாலிட்டி ஆஃப் லைஃப்பை மெயின்டைன் பண்ணுறதுக்கான அட்வான்ஸ்மெண்ட் சர்ஜரிஸ் இருக்கா?
That is a misconception. Most of the cancer surgeries will not cause weight loss. Okay, most of the patients, even after cancer treatment, they started gaining weight. One word I can tell is all cancers can be treated. Most of the cancers can be cured.
தினமலை நேயர்களுக்கு வணக்கம். இந்த ஸ்பெஷல் பாட்காஸ்ட்ல நம்ம கூட டாக்டர் ஸ்ரீ கார்த்திக் வாலேட்டி சர்ஜிக்கல் ஆன்காலஜிஸ்ட் இருக்காரு ஃப்ரம் ரேடியல் ரோட் காவேரி மருத்துவமனை.
வணக்கம். வணக்கம்
டாக்டர். இப்போ நம்ம ஆன்காலஜிஸ்ட் அப்படின்னு பார்க்கும்போது ஃபர்ஸ்ட் இப்போ மக்கள் அந்த கேன்சர் ஒரு ப்ராப்ளம் டயக்னோஸ் பண்ண வராங்கன்னா அவங்க வரது ஃபர்ஸ்ட் மெடிக்கல் ஆன்காலஜிஸ்ட் கிட்ட வராங்க. அப்போ எந்த ஒரு டிரான்சிஷனில் டாக்டர் அவங்களுக்கு வந்து சர்ஜிக்கல் ஆன்காலஜி அப்படிங்கிற ஒரு ஸ்ட்ரீம் தேவைப்படுது? எனக்கு என்ன சர்ஜிக்கல் ஆன்காலஜின்னு ஒரு ஸ்பெஷலைசேஷன் இருக்கிறதுனால நான் கேட்குறேன், எல்லா கேன்சர் ட்ரீட்மெண்ட்ஸ்க்குமே சர்ஜரி அப்படிங்கிறது ஒரு தேவையா? ஸோ வாட் இஸ் த டிஃப்ரென்ஸ்? பேசிக்கலி என்ன டிஃப்ரென்ஸ் ரெண்டு ஆன்காலஜிஸ்ட்டுக்குள்ள எப்போ ஒரு ஆப்ரேஷன் அப்படிங்கிற சர்ஜரி அப்படிங்கிறது தேவைப்படுது?
See, surgical oncologist is a அறுவை சிகிச்சை doctor. Medical oncologist is a மருந்து கொடுத்த doctor. So, just like general medicine and a general surgeon, in oncology, there is a medical oncologist and a surgical oncologist. Fine. So, most of the cancers, it is not that they go to medical oncologist initially. It depends on the cancer type. For example, a breast lump, they come to a surgeon first. இன்னொரு இது வந்து endometrial cancer, that is a கர்ப்பப்பை கேன்சர், ப்ளீடிங் வருதுன்னா they come to a gynecologist or cancer surgeon. So it depends on the cancer, what they are having.
பட் இந்த கன்ஃபியூஷன் இப்போ இருக்குல்ல டாக்டர், இப்போ ஆன்காலஜிஸ்ட்லேயே ஒரு 2 பேர் இருக்காங்க அப்படின்னா, நான் ஒரு நார்மல் பேஷண்ட்டில் இருக்கேன்னு வைங்களேன், யார்கிட்ட போகணும், இப்போ இந்த பிரச்சனைக்கு இவர்கிட்ட போகணுங்கிறதே ஒரு இனிஷியல் ஒரு கன்ஃபியூஷன் மாதிரி இருக்காது. ஸோ ஹவ் டு பீப்புள் ஐடென்டிஃபை லைக் இந்த ப்ராப்ளம்க்கு நம்ம இவங்க கிட்ட போகலாம் அப்படிங்கிறது?
Actually there are three people, medical, surgical and radiation
oncologist.
Okay, it is no need, it is not a hard and fast rule that I have to go to a surgeon, surgical oncologist or medical oncologist. Any person who is well experienced or well versed in seeing oncology patients, they can go to them, because all oncologists, ella oncologists, they know இந்த பேஷண்ட் கீமோ கொடுக்கணுமா, இந்த பேஷண்ட்க்கு சர்ஜரி பண்ணணுமா, இந்த பேஷண்ட்க்கு ரேடியேஷன் கொடுக்கணுமா, they know very well. So one patient, once they come, after evaluating, if a patient comes to me, I evaluate, and if I feel chemotherapy is needed for this patient, I'll send them to medical oncologist.
Okay.
Like the same way, vice versa. If a patient comes to a medical oncologist, like a breast lump, sir evaluates, and he feels that this patient needs surgery, then he will send it to me. So it is like we oncology, three doctors are interconnected. It is
Okay.
never as an individual doctor.
Okay.
Oncology practice is a group practice. So me, medical oncologist, radiation oncologist, it is all who we work as a team. So whatever is happening to anyone, we will get to know.
Okay.
It is not like I will totally get disconnected from a patient if I don't see them. It is like we are constantly on the loop. This is what which keeps us apart from other specialities, and also this practice is very, very good in our hospital.
Okay.
So we have a constant communication between each and every doctor. Not only doctors, we communicate with the radiologist, we communicate with the pathologist, we communicate with the nursing, physiotherapy, dietitian, each and every person who is responsible for an oncology patient treatment are continuously in a loop to give the best care to the patient.
So it's a multidisciplinary
Yeah, it's a
stream.
multidisciplinary team, and who all I told you are there in this team.
Okay. So there are popular cancer types இருக்குல்ல டாக்டர். ஃபார் எக்ஸாம்பிள் பார்த்தீங்கன்னா எல்லாருக்குமே தெரிஞ்சது பார்த்தீங்கன்னா பிரஸ்ட்,
Yeah.
அப்புறம் சர்விக் தெரியும், அதுக்கப்புறம் ப்ராஸ்டேட்ஸ் தெரியும்.
Mm.
இப்போ இந்த மாதிரி விஷயங்கள் எல்லாமே மெடிக்கல் ஆன்காலஜி, அதாவது மெடிசன்ல கியூர் பண்ணலாங்கிற ஒரு ஸ்டேஜ் இருக்குமா, இல்லை எடுத்தாலே இதுக்கு வந்து சர்ஜரி மட்டும்தான் ஒரு கியூர்னு இருக்குமா? ஸோ அட் பாயிண்ட் ஆஃப் டைம் எப்போ சர்ஜரிங்கிறது இன்வால்வ் ஆகுதுன்னு?
Yeah. So I'll tell you simple thing. If it is a breast cancer, we'll take example as
Breast
a breast
cancer.
cancer. In breast cancer, before the treatment used to be stage based. Stage 1, stage 2, stage 3, operation பண்ண முடியுமா ஆப்ரேஷன் பண்ணிக்கோங்க, அதுக்கப்புறம் கீமோ கொடுக்கலாம். இப்போ அப்படி கிடையாது. No, we see not only stage, we bring in the molecular subtypes. இது என்னன்னா, each patient will have a different tumor on a DNA basis mutation analysis. So we do molecular subcategories of a cancer. That is, each cancer will behave differently. If two people are there, two women are there, both have breast cancer, but both may not be the same. Although they're same stage,
same age,
same age, even if they're living in the same street or same home, they might have a different molecular subtype.
Okay.
So we treat according to the molecular subtype and stage combined together.
Okay.
So for some molecular subtypes, even in stage 1, we give chemo unless until it is very, very early. For some molecular subtypes, even a little bigger tumor also we opt for surgery. So that we call it as a lumina A tumor, which we give surgery, or a triple negative or HER2 we give chemo or targeted therapy or immunotherapy and then do surgery. So it doesn't depend on stage alone in breast cancer. So it is a patient-centered treatment.
Okay.
Each patient is different and we give treatment according to the patient tumor.
ஸோ அதுக்கப்புறம் ஒரு நம்பர் 1, நம்பர் 2 அப்படிங்கிற மாதிரிலாம் கிடையாது. அந்த பேஷண்ட் எவால்வேட் பண்ணி அவங்களுக்கு என்ன தேவைப்படுது அப்படிங்கிறத தான் நம்ம பார்க்கணும்.
Yeah, that is the latest treatment.
Fine, doctor.
So WHO also has mentioned this thing called united by unique. So each patient is unique, but they are united by cancer, fighting against cancer. So the uniqueness of each cancer in a patient is what we are treating.
ஸோ அந்த அப்போ எவால்வேட்டிங் ப்ராசஸ் தானே டாக்டர் ரொம்ப பெருசாக இருக்கும்?
Yeah. See, most commonly it will take around 1 week to 10 days for the entire evaluation. There are some rare exceptions where we might not need to evaluate much. Like if it is a less than 1 centimeter tumor, we tell go ahead with surgery.
Okay.
We don't need to wait. We'll just do a biopsy, confirm it is tumor, and if it is tumor, we go ahead with surgery, even though we don't see the molecular subtype. But there are some times where we will not be able to find a particular tumor. We might need to do a repeated biopsy and all. So on an average, it will take 1 week to 10 days, because sometimes we might do a CT, sometimes we might do an MRI, and sometimes when we think it is spread somewhere else, or we want to rule out whether the cancer has spread to other parts of the body, appo PET CT தேவைப்படும். So PET CT பண்ணிட்டு அது பார்த்துட்டு அதுக்கப்புறம், and before treatment in our hospital, what we do is we all discuss together, me, medical oncologist, radiation oncologist, pathologist, radiologist, multidisciplinary tumor board we tell. This is very important in cancer treatments nowadays. It is not like I want to do surgery means I cannot do surgery. Our team has to accept, because what it does is it improves the patient care, it improves the patient outcomes.
Okay.
Because it is not one doctor alone taking the decision. It is all doctors, and we come to a particular pathway where we follow. We don't deviate. If we say this patient needs chemo after that surgery, then after that radiation, we follow that same path. So because what it does is it streamlines the treatment for the patient and also improves the outcome.
ஓகே. ஸோ ட்ரெடிஷ்னலாக அந்த பெஸ்ட் கேன்சருக்கான சர்ஜரினும் போது மக்களுக்கு இருக்கிற ஃபர்ஸ்ட் தாட் என்னன்னா யூ ரிமூவ் த பிரெஸ்ட்.
Yeah.
அது பிரெஸ்ட் ரிமூவ் பண்றதுங்கிறது சைக்காலஜிக்கலாகவும் அஃபெக்ட் பண்ணும் ஒரு பெண்களை.
Yeah.
அப்படி இருக்கும்பொழுது இப்போ நான் ஒரு சர்ஜன் உங்ககிட்ட வரேன் அப்படின்னா வி டாக் அபவுட் ப்ரிசிஷன்ஸ் டாக்டர் நவடேஸ் ரேடியேஷன்ல வந்து டார்கெட்டட் தெரப்பிலாம் பேசுறோம். அப்படி இருக்கும்பொழுது இன்னும் அந்த கேன்சர்ஸ்க்கு நம்ம ஃபுல் பிரெஸ்ட்டை தான் ரிமூவ் பண்றோமா இல்லை அதில் ஏதாவது ப்ரிசிஷனான சர்ஜரிஸ் இருக்கா?
Yeah. See, this breast cancer treatments date back to some very 2-3 centuries before. First treatment was to remove the entire breast and axillary lymph node, skin over the breast. That was Halstadian mastectomy. That is called. It's a very morbid procedure. They'll remove all the muscles and all. Coming to now, we don't remove the entire breast. We remove only the tumor and a little bit of breast tissue around the tumor. And lymph nodes also we don't remove completely. There is a thing called sentinel lymph node. What it does is in that we give special dyes and identify where it is going. If it is going to that lymph node, we'll remove that lymph node alone. That is the first draining lymph node. That means if a tumor has to go through also, it has to go through the lymph node only first. So we remove that first lymph node and check it under microscope. And if it is involved only, then based on how it is involved, what are there are certain characteristics. If these characters are there, then only we do axillary dissection, that is removal of all the lymph nodes. Otherwise, we don't need to remove. In early breast cancer, almost 90% can be treated with this treatment alone.
Okay.
No need of removal of breast and no need of removal of all the lymph nodes. Just the tumor and a little bit of breast tissue and a sentinel node. Only in 10% where it has multiple tumors are there, or when we do breast conservative surgery, or the patient is not willing for breast conservation because we can't treat against the patient will, then only we go for mastectomy. Okay. But most of the early cancers we can remove that alone. What it does is, see, you know that breast is called epitome of femininity. So it is not only beauty consciousness but also motherhood thing. It is deeply connected to a female's confidence and females how they go out into the society. Once the breast is removed, we call it as going flat. The female tends to withdraw from the society. They don't go out. Psychological. So once the breast is preserved, automatically the female she will not feel that psychological issues. She'll be confident. She'll be going out. She'll be able to carry her normal work.
ஓகே. இப்போ அந்த மாதிரி நீங்கள் சொல்கிற அந்த டிஷ்யூ இல்லை அந்த ப்ரிசிஷனுக்கான சர்ஜரி இருக்குன்னு வைங்க டாக்டர், அகைன் அது க்ரோ ஆகிறதுக்கான பாசிபிலிட்டிஸும் இருக்குமா? இல்லை அந்த அளவுக்கு இல்லாமல் நம்மளால் 100% ப்ரிசிஷனாக அந்த ஆப்ரேஷன்ஸை இப்போ பண்ணுற அளவுக்கு டெக்னாலஜிஸ் இருக்கா?
See, whatever we remove, we immediately see under microscope whether the entire tumor has been removed or not. By doing this, after that we have to give radiation also. By doing this, 95% of the times we can prevent it from coming back.
Okay.
5% we cannot guarantee. At the same time, not even 5, less than 5%. And at the same time, you have to understand all the studies showed so far, whatever we have done, removing the entire breast, removing the tumor alone, didn't have any survival difference. That means a person in whom we are removing the entire breast, மார்பத் எல்லாம் ரிமூவ் பண்ணிட்டாங்க, டியூமர் மட்டும் ரிமூவ் பண்ணிட்டாங்க, அந்த 2 பேர் கம்பேர் பண்ணிட்டாங்க. நிறைய ஸ்டடீஸ் கம்பேர்ட் திஸ் 2 groups and most of them found that, all of them found that the survival is same between the 2 groups.
Okay.
So that means it is as equal as removing the entire breast.
So sir, இதை வந்து நம்ம ஒரு டெக்னாலஜிக்கல் அட்வான்ஸ்மெண்ட் எடுத்துக்கலாம் இல்லையா?
It is everything is a technological advancement. With the latest before the tumor diagnosis was done after surgical removal. Now we are biopsying it, identifying it before. Now the latest, what technological advances over a period of time we found out that with the help of technology and the breast tumor வந்து அங்க மட்டும் in the surrounding only little bit will be there. No need to remove the entire breast. Before they used to think the tumor will first invade the breast, then go to the axilla, then go to the body. Now it is not like that. With the latest technologies, what we found is the tumor here will go to the axilla or into the blood even when tumor is small. So there is no advantage of removing the entire breast.
Okay.
And over a period of over a period of decades, what we found out with latest surgical advancement, we found out different techniques where even a tumor is removed, a huge chunk of tumor is removed, we can readjust the breast tissue or the fat around the breast in such a way that the breast looks similar to the opposite
அது
breast.
பிளாஸ்டிக் சர்ஜரி அந்த மாதிரி டாக்டர்?
Yeah, it is called as oncoplasty.
ஆன்கோபிளாஸ்டி.
So what is oncoplasty? It is like a surgical oncology, that is cancer surgery with plastic surgery combined together is called oncoplasty.
ஆன்கோபிளாஸ்டி. ஓகே.
So first preference is oncology. In that oncoplasty also we give preference to cancer. That is, we have to remove the complete tumor, then only reconstruction.
Fine. இப்போ பெண்களுக்கு வந்து பிரஸ்ட் கேன்சர்ல அந்த சர்ஜரின்றது காமன் மாதிரி, ஆண்களுக்கு வந்து ப்ராஸ்டேட் அப்படிங்கிற விஷயம் காமனா இருக்கு. அப்போ ஒரு 30 பிளஸ் அப்படின்னு. அதுல இப்போ என்ன சர்ஜரி அட்வான்ஸ்மெண்ட்ஸ் இருக்கு டாக்டர்?
See, prostate cancer is common in men, especially more than 55 years. So most of the advances came in the form of minimal invasive surgery for early prostate cancer. And radiation, latest advances in radiation, where we give radiation only to the prostate, that is called as brachytherapy, and robotic surgery. See, before they used to have big incision, and they used to have, it bleeds a lot, prostate surgery. And what happens is when
It's a cut and open surgery.
yeah,
before.
cut on before we have to cut open, go remove the prostate. What happens is after that prostate is removed, the quality of life was poor. Now with the latest robotic and laparoscopic surgeries, what they are able to do is they are able to preserve the nerves which help in passing urine after the surgery, at the same time maintaining sexual health. So what's happening, even when the prostate is removed with the latest robotics, after the surgery is done, the patient is able to have near normal life. Okay. That means the quality of life is improved. Before, they used to think about cure of cancer. Now we not only think about the cure of cancer, but also we think about the quality of life. See, we cannot just make a person's life miserable just in the name of curing cancer. That is the current role. We will think about how his life will be after the surgery. We have to make sure that he lives a near normal life. The motto is to have a new, stronger and more confident life after cancer surgery. That is not only cancer surgery, cancer treatment. Any treatment, we are aiming at improving the quality of life. These are the latest advances.
ஸோ ஆஸ் அ பிரெட் வினர் ஒரு ஃபேமிலியில் ஒரு 50 இயர்ஸில் இருக்கார் ஒருத்தர் அப்படின்னா, அவருக்கு நம்ம இந்த ப்ராஸ்டேட் கேன்சருக்கு ஒரு ட்ரீட்மெண்ட் ஒரு ஆப்ரேஷன் சர்ஜரி பண்ணுறோன்னா, ஹவு ஃபாஸ்ட் ஹி கேன் ரெக்கவர் ஃப்ரம் தட் டாக்டர்?
It depends on the stage. Ultimately, what we are doing, it depends on what it is. But if you are doing a surgery, he'll be able to get back to his normal life within 1 month. Most of them will become normal within 3 months. He will be having his own work life. And with the latest treatment, he'll be taking some hormone tablets if needed. These are the things, basic needs which are there. But most of them will have a normal life within 2 to 3 months.
ஸோ நீங்கள் ஒரு மென்ஷன் பண்ணியிருந்தீங்க டாக்டர், அது முன்னாடி சொல்லுவாங்க இல்லையா, ப்ராஸ்டேட் ஆப்ரேஷன், கேன்சர் ரிமூவ் ஆப்ரேஷன் பண்ணிட்டா தே கான்ட் ஹேவ் அ செக்ஷுவல் லைஃப் பேக் அப்படின்னு. அது எப்படி டாக்டர்?
See, that the prostate will have the nerves for the sexual organ will be surround, they come down.
Connected.
No, not connected. They come down over the prostate. So before they used to do, when they used to remove, it used to bleed a lot, and the surgical anatomy and the surgical techniques evolved over a period of time. Now we know where exactly the nerves are between the prostate capsule and the outer capsule. They know the nerves, so they go below the nerves and preserve the nerves and remove it. Fine. The main disadvantage for prostate, it is deep below in the pelvis. See, it is like in the well.
Okay.
So when they're doing open surgery, most of the surgery is blind. They're not able to see properly. Fine. They'll just blindly do the surgery most of the times. Even though if they see, the magnification is very, very less. So the movements of the hands also, the pelvis will be narrow. Okay. You cannot engage your hands into the pelvis and do a proper, what do you say, more accurate or more precise surgery will be difficult. But with the help of lap or robotics, what is there, it is all magnified. You will see the prostate this big, and you'll be able to see the nerves, the layers between the prostate and the nerves, and you are able to go between that and remove the prostate. So the sexual life will also be good. Once you preserve the nerves, automatically his quality of life is a lot better.
ஓகே. ஸோ யூ மென்ஷன் ரொபாட்டிக்ஸ் டாக்டர். இப்போ ரீசெண்ட் அட்வான்ஸ்மெண்ட்ஸில் எல்லா மெடிக்கல் ஃபீல்டு அண்ட் எல்லா சர்ஜரிஸுமே வந்து ரொபாட்டிக்ஸ் வந்து நிறைய வந்துருச்சு. ஏஐ இன்கார்பரேட் பண்ண ஆரம்பிச்சிருக்காங்க. ஸோ இப்போ இந்த நம்ம ஆன்காலஜியோட சர்ஜரிஸை பொறுத்த வரைக்கும் எவ்வளோ தூரம் நம்ம ரொபாட்ஸை யூஸ் பண்ணிக்கிட்டு இருக்கோம்? இப்போ ரீசெண்ட் அட்வான்ஸ்மெண்ட் இந்த விஷயத்துக்கு நம்ம ரொபாட்ஸை யூஸ் பண்ணுறோன்னா எது சொல்லலாம்?
See, robotics in oncology, it's like expanding like crazy. It's been in every part of the body. Many people we started doing robotics in starting from head and neck cancer, thoracic cancer, GI cancer, urological cancer, even gynecological. For you, if you ask me what are the basic cancers where robotics is classically established, it is established for prostate, rectum, stomach, colorectum, thoracic cancers. They are standard. And even the people are expanding to head and neck surgery, like thyroid surgery, they are doing robotics. And especially it is very, very helpful in thoracic cancers and deep pelvic cancers, that is the tumors which are deep inside the pelvis. So what is the advantage, you can ask me? If you ask me, see, robotics, with the help of robotics, there is a lot of AI. We can add in the imaging into the robotics, which is coming up. And there is something called indocyanine in green technology, where we'll be able to identify few structures with the help of it, and we can have a proper dissection. Main thing is post-operative recovery. If you do an open surgery, not only robotic, laparoscopic also, the advantage is post-operative recovery. It is very, very quick. If you do an open surgery, for example, a simple hysterectomy we give incision from here to here. This much big incision we give. And patient will be admitted in hospital for 3 to 5 days. Patient will have pain on movement. She coughs, she will have movement. She gets up, she will have movement. She passes motion or urine, she will have pain. And they will not move out of the bed because of pain. But if you do in laparoscopy or robotic, you'll have small 1 centimeter or less than 1 centimeter incisions, 4 to 5 maximum. And next day, the patient will be sitting in the couch.
Okay.
She'll be smiling. See, that is the advantage. Have you ever imagined a patient who underwent a surgery before day sitting on a couch and smiling the next day?
Okay.
That is the advantage of minimal access. Minimal access is both robotic and laparoscope. Both are equal.
So layman terms lo understanding na robotic surgery na robo da vandu surgery pannu. It's not like that, right?
No.
It's a tool like that doctors use to.
Robot is like a puppet. See,
okay.
For me, to what I decoded is, it is like a puppet. See, before, when puppets are moving, the puppeteer will move one finger like this. Yes. So the puppet lifts a hand like that. Almost the similar technology. The robot will have a console and a patient cart and the master console. That is, all the CPU, everything will be there. The patient cart is the one which stands near the patient. It will have arms. So what we do is, we'll attach a specific instrument to each arm and a camera also. Once the arms are placed inside the abdomen through surgically, the surgeon will go and sit on the console. Now he feels like he's seeing from inside the abdomen, like his head is inside the abdomen. Right. And these arms will become an extension of his hands.
Okay.
So as soon as he move, there are specific movements. So if you just like, what do you say?
It's a console of game or
a game madra. So when you move the arm like this, the robotic arm also moves like this.
Okay.
If you do like this, the robotic arm opens. If you hold like this, the robotic arm holds like this. So that is a puppet. It is fine. All the movements of the surgeon are mimicked or mirrored by the robot. But what is the advantage? Small incisions, better magnification, and the movements are more precise. Okay. So what happens is, you will have better patient post-operative outcomes.
இப்போ நிறைய இந்த லங் கேன்சர்ஸ் இருக்கு, இந்த மாதிரி இன்னும் ஒரு சீரியஸான ஸ்மோக்கிங் காசஸ் கேன்சர்ஸ்லாம் இருக்குல்ல டாக்டர். இப்போ அந்த மாதிரி விஷயத்துக்கு நம்ம எப்படி சர்ஜரிஸை யூஸ் பண்றோம்? லைக் சில விஷயங்களை நம்மளால கட் பண்ணி த்ரோ பண்ண முடியாது, சில விஷயங்கள் அந்த இடத்துல நம்ம ஆப்ரேட் பண்ணும்பொழுது அது லைஃப் த்ரெட்டனிங்காக இருக்கலாம். அப்படின்னும் பொழுது அந்த இடத்துல நம்ம சர்ஜரிஸை வந்து எவ்வளோ தூரத்துக்கு அட்வான்ஸாக கொண்டு போயிருக்கோம்? இந்த லைஃப் த்ரெட்டனிங்கான சர்ஜரிஸ் கேட்டு சொல்றேன்.
See, what is a life-threatening surgery is when you have to remove a critical organs, or yes, critical structure. For example, if you take in lung, it is involving the aorta, or it is involving the heart, or it is involving something like a spinal cord like that. We will not do surgery. So at these kind of things, what we do is, latest treatment is we give chemotherapy, immunotherapy, targeted therapy in lung cancer. Okay. So we'll decrease the tumor size
ஸோ
and
அப்போ
give
நம்ம எக்ஸ்பிளைன்
radiation.
நம்ம அண்டர்ஸ்டாண்ட் பண்ணலாமா டாக்டர்? எந்தெந்தெல்லாம் கொஞ்சம் லைஃப் த்ரெட்டனிங் ஆர்கன்ஸ் இருக்கும், அங்கே நம்ம சர்ஜரிஸ் இல்லாமல் வேற ரேடியேஷன்
Yeah,
தெரபிஸ்
we
மாதிரி?
try to do something else other
Fine.
than this. There are few cancers where few stages in cancer, we call it as locally advanced, although it is not spread anywhere, we call it as locally advanced unresectable cancers.
ஓகே.
So there we try to avoid surgery, give other forms of cancer treatment and make his lifespan prolonged.
ஸோ இப்போ நீங்கள் சொன்னீங்களே டாக்டர், ஃபர்ஸ்ட் அந்த ட்ரீட்மெண்ட்டுங்கிறது பேஷண்ட்ஸோட வில் அப்படிங்கிற மாதிரி
ம்.
சொன்னீங்க. இப்போ சர்ஜரிஸுங்கிறது பேஷண்ட்டோட வில்லா? லைக்
ம்.
எனக்கு சர்ஜரி வேணாம், இப்போ நம்ம சொல்லுவோம் இல்லையா, எனக்கு ஊசி வேணாம் மருந்து
ம்.
கொடுங்கன்ற மாதிரி நம்ம இந்த கேன்சர் ட்ரீட்மெண்ட்ல கேட்குற மாதிரி இருக்கா என்ன?
See,
தெர் இஸ் ஆப்ஷன்ஸ் லைக் திஸ் ஆர் தட்ன்ற மாதிரி ஆப்ஷன்ஸ் இருக்கா?
yeah. See, for example, I'm telling you, for example, there is a cancer stage where you can give surgery
Mm.
or radiation. For
Mm.
example, tongue cancer, very early cancer, small thing is there. You can do surgery or radiation.
ரேடியேஷன்.
There will be cons and pros of both.
Okay.
Surgery has its own advantages,
Mm.
own disadvantages. Radiation will have its own advantages and disadvantages.
ஓகே.
So we explain everything to the
Mm.
patient. So they will take the call.
ஓகே.
Okay. For example, he doesn't want any surgery. If other alternative treatment is having the same cure as surgery, then we give the option to them.
ஓகே.
But there are certain cancer types where we cannot avoid surgery.
Mm.
For example, in ovarian cancer, you take where we give chemotherapy along with surgery, especially advanced ovarian cancer, we give chemotherapy. It reduces a lot.
Mm.
Or breast, it reduces, decreases in size. But after that, surgery is needed.
Mm.
Why? Because chemotherapy cannot kill 100% of cancer cells. Okay, it is just certain fraction of cancer cells which are killed. Rest of the cancer cells will be there, one or two, we don't know. There we have to remove this. Surgery might be needed.
ஸோ சர்ஜரி இஸ் த ஒன் திங் 100% அதை ரிமூவ் பண்ண.
Not for all cancers. That's what I'm telling you. When there are alternative treatments to surgery and the patient is not willing, then we can give. And there are certain cancers where we don't do surgery at all as a primary treatment, like leukemias, lymphomas. We don't do surgery at all. For them, chemotherapy is the main thing. Few cancers like cervical cancer and all, radiation is the main thing. But even in cervical cancer, early stage, we do surgery. Like that, based on the stage and organ and type of cancer, we decide whether to do surgery or chemo or radiation or all together.
Okay.
Or any two of them. Okay, for few head and neck cancer, we do surgery and give radiation. For few breast cancers, we give chemo, surgery, radiation all together. Sometimes targeted therapy also. It does. That's what I'm telling you.
இட்ஸ் நாட் பேஷண்ட்ஸ் கால் கிடையாது, டாக்டர்ஸ்
Patients call kadiyadu.
கிடையாது.
We
இது
we
மட்டும்
will advise.
ஃபைன்.
We have to give them the best possible treatment.
Okay.
And see, for a same cancer, we can give chemo and then surgery, surgery and then chemo.
Hmm.
That we decide based on the patient quality, performance status also. If the patient is very healthy, she will be able to tolerate a major surgery, we do surgery and then give chemo.
Okay.
Or if the patient is not so healthy, her performance status is a little poor, then we will give chemo. In that time, we improve her performance status and then do surgery.
Okay.
So it depends. But most of the cancers where surgery is needed, we have to advise surgery. If the patient tells, I don't want surgery at all, then we have to explain and educate her in such a way that she accepts for surgery.
டாக்டர், இந்த இன்வால்மெண்ட் ஆஃப் சர்ஜிக்கல் ஆன்காலஜி அப்படிங்கிறது இந்த ஸ்டொமக் பகுதியில் அதிகமாக இருக்குது அப்படின்னு நினைக்கிறேன். லைக் மல்டிபிள் திங்ஸ் அந்த இடத்துல நிறைய பிரச்சனைகள் வருது. ஸோ அந்த இதுக்கு என்னென்ன மாதிரியான ப்ராப்ளம்ஸ் இருக்குது, அதுக்கு என்னென்ன இப்போ அட்வான்ஸ்மெண்ட் டெக்னிக்ஸ் இருக்குது டாக்டர்?
See, as we go on day by day, the cancers in young people are increasing, especially rectal cancer, colon
இஸ் இட் ட்ரூ
cancer.
டாக்டர்? லைக் உண்மையிலேயே வந்து இன்க்ரீஸ் ஆகுதா, இல்லை அதை சும்மா
இல்ல.
பயமுறுத்துற மாதிரி சொல்லுங்க.
See, there are two reasons why it is increasing. One is more diagnosis, that we are, as awareness is
அவேர்னஸ்
increasing,
இன்க்ரீஸ்.
more people are coming forward to get checked and we are finding. One more reason is unmayame, the cancer incidence is increasing.
ஓகே.
I think if when we were kids, we used to see one or two cancer patient in the entire village. Now if you take in a street, one or two cancer patients are there. That's because there are many factors for that we, if we discuss, it will become like another podcast.
Okay.
But it is increasing now because of this young patient, and also the cancer average age of diagnosis of cancer is coming down. It is coming down to 50s. So in future we don't know, it might come down to 40s also. So and if you take especially in Tamil Nadu and southern India, stomach cancers are very common. When
ஸ்டொமக்ல என்டையர்லி எங்க டாக்டர்?
illa main stomach,
ஸ்டொமக்
main stomach, and even rectal and colon cancers are increasing.
இன்க்ரீசிங்.
And What is the role of a surgical oncologist in these cancers, if you ask me? See, in stomach cancer, if it is an early stage, surgery will help. Or even in advanced stage 3 stomach cancers also, we are able to do surgery and give a improved lifespan and also quality of life. If it is stage 4 or it has spread somewhere, then we cannot help. Then we have to accept the disease at one point of the time. But still, with the latest treatments, even if it is spread to the peritoneum, we are able to do surgery and cytoreductive surgery, and we give chemotherapy directly into the abdomen, called cytoreductive surgery and hyperthermic intraperitoneal chemotherapy. This surgery is called, it is two parts. One part will remove all the visible tumor, one part we give chemotherapy. And in stomach cancers, with the latest advances, we are able to do in minimal access way, that is keyhole surgery, either laparoscopic or robotic. We are able to remove the entire tumor. Like similar to other robotics, it has its advantages. Quick recovery, quick going back to home. Within no time, patient will be going back to his work. And the post-operative pain is also very, very less. And if you take what I have, when I have to see a doctor, or what is there any specific things when I have to visit a doctor? Yes, when there is some altered in your bowel habits, that is, patient is having alternate diarrhea followed by constipation, or some blood in the stool. These are the two most common
பட்
things.
அவங்க ஏன் டாக்டர் இந்த மாதிரி ப்ராப்ளம்ஸ்க்கு ஆன்காலஜி கிட்ட வருவாங்க? அவங்க
இல்ல, that's what.
ஜஸ்ட் அது வந்து இப்போ இது ஒரு கன்ஃபியூஷன் தான் டாக்டர். இந்த மாதிரியான சிம்டம்ஸ் எல்லாம் வேற சில ப்ராப்ளம்ஸ்க்குமே
Yeah.
இருக்கும் இல்லையா?
See, in a bleeding in rectum patient, almost most of them are benign, like piles or a
Piles
fissure
இருக்கலாம்.
or some other polyp. But the chances of cancer, if the patient is having these symptoms, is a little higher.
Fine.
Okay, that's why you have to go to a proper doctor. See, most of them, what they do is they go to a doctor who is not trained in seeing these kind of cases. What they do is 2-3 months they do alternative treatments, or they give some treatment, and the patient will not have proper symptom relief. What is happening in this time is you are losing the golden period of treating the cancer early or catching the cancer early, if it is there.
Okay.
That's what I'm telling you. If they go to a proper doctor, they evaluate and find out there is a cancer and it is in early stage, we can treat early. But if they go to another doctor and they're dilly-dallying, they're not able to diagnose, and they will give other treatments thinking of something else, and the patient comes to us in a late stage. After a very long time, okay, chalo, this symptoms are not reducing. We'll do a CT scan. They will think after some 2-3 months or 6 months, then they will find that there is cancer, and then come to us. So what is happening there? That 6
They are
months is
losing the
delayed.
6 months.
Yeah, that's what. So I'm not telling you go to a cancer doctor immediately you see blood in a stool. You go to a doctor like a proper general surgeon who knows how to evaluate.
Fine.
That is what I want to tell you. Go to a person who is specific for that particular symptom. For example, you are having cough, fever, will you go to a surgeon or a medical doctor?
No, normal.
Medical doctor.
Medical doctor.
Similarly, when there is a surgical symptom, you have to go to a surgical doctor. That's what I want to mean.
There is a saying, டாக்டர், லைக் இப்போ நம்ம அந்த வயித்துல இருக்கிற கேன்சர்ஸ்ல ஏதாவது இருந்து அதுக்கான நம்ம ஒரு ஆப்ரேஷன்ஸ் பண்றோம்னா அதுக்கப்புறம் தே லூஸ் தர் appetite, தே லூஸ் தர் வெயிட், அவங்களால ரெகுலர் ஃபுட்ஸ் எடுத்துக்க முடியாது அப்படிங்கிற ஒரு ட்ரெடிஷ்னல் மெத்தட் இருந்தது. இப்போ இருக்கிற அட்வான்ஸ்மெண்ட் மெத்தட் என்ன அந்த மாதிரி தான் வச்சிருக்குமா, இல்லை நீங்க சொன்ன மாதிரி என்னோட பேக் டு அந்த குவாலிட்டி ஆஃப் லைஃபை மெயின்டைன் பண்றதுக்கான அட்வான்ஸ்மெண்ட் சர்ஜரிஸ் இருக்கா?
See, when we are doing a surgery, there are few things which you have to accept. For example, when we remove a part of stomach, some nutrients which are getting absorbed into the stomach will not be absorbed. So we will give you supplements.
Fine.
That you have to follow up.
Fine.
But if you ask me whether my appetite will decrease, I'll lose weight, that is a misconception. Most of the cancer surgeries will not cause weight loss. Fine. Okay, most of the patients, even after cancer treatment, they started gaining weight. Most of the patients after the treatment, once they start recovering from the cancer, they start gaining weight. That is a good sign. That is a myth that they will lose weight. And second thing is, when we do a rectal cancer surgery, initially people will have some difficulties in the form of passing motion 3-4 times in a day. Colon surgeries also, they pass motion a little more number of times than normal. But you have to understand your body is like it adapts to anything. Magic happens. Within 3 months, you will have your near normal life. Okay, but the thing is that you have to be on constant follow-up with the cancer doctor.
Okay.
That one thing you should not miss, because if there is any symptom is there, he will help you how to avoid it, or how he will treat that symptom,
Okay.
so that you will feel better. You will have a normal life. That there is no hard and fast rule that this surgery causes weight loss, this surgery will make you debilitated. All the surgeries are done to improve the quality of life, and the patient will have near normal life.
So the colon cancer க்கு the minimal invasive surgery அப்படிங்கிற thing இருக்கு.
Colon and rectum, we have laparoscopy and robotic. Even right side of the colon, left side of the colon, rectum, we have removed the entire colon with the rectum also. We have done under minimal access surgery. So minimal access surgery is especially useful in low rectal cancers and advanced rectal cancers. So what happens is, in rectal cancers, most of the patients we give chemotherapy, radiotherapy, and then take up for surgery. In colon cancers, we do surgery first. That is a different ballgame. But in rectum, we do give radiation and chemo and then do surgery. The planes are very, very difficult. And like how prostate cancer, rectal cancer also involves nerves to the bladder.
Okay.
So if you don't do properly, patient will have a bladder urinary incontinence, or urinary, they're not able to pass urine properly. So with the help of this laparoscopy or robotics, we are able to do good rectal surgeries, even though low tumor. In some cases where few people will tell you will not be able to pass motion via natural orifice, where you might need a stoma, with the help of this robotics or laparoscopy, we are able to preserve that sphincter mechanism and give, we can avoid a permanent stoma.
Okay.
See, stoma is needed for some time, but once the surgical healing occurs, we can put it back and he will have a normal life.
Okay. The surgeries in gynec cancers எப்படி இருக்கு டாக்டர்?
See, gynec cancer after breast, those are the most common cancers in women. Most of the endometrial cancer, they present at an earlier stage.
Okay.
And the standard is minimal invasive surgery.
Not to remove the entire thing.
No, we remove the entire thing. See, even in young women, we can do fertility preservations. There are certain criteria where we don't remove the uterus and try to preserve one of the ovary. But that criteria should
they
not...
can have a baby.
They can have a baby, but that criteria should be met. Even when we are removing both the ovaries also, then we have the latest advances in the form of embryo preservation or ovum preservation, where we I mean, like, if for example, I'm telling you, a 32-year-old married woman came to us. She got recently married, like 1 year back. They're trying for a baby and found to have bilateral ovarian cancer or tumor, which is a low-grade tumor. So in these people, we don't need to remove the uterus. What we do is either we stimulate the ovary and take out the womb and fertilize with sperm, and we form an embryo and preserve it. And later, with the help of fertility doctors or gynecologists who are trained in fertility treatments, they can have a normal baby in their own uterus. Okay. And even in uterine cancers, there are if they meet certain criteria, we'll be able to preserve the uterus, and then they can have a normal baby, and then we can remove the uterus.
Okay.
So no need to remove the uterus or ovaries.
We can prolong it actually.
Yeah, they can prolong it. In ovaries, they have to meet certain criteria. Then we will be able to preserve. If they don't meet that criteria, or if the ovaries have to be removed, still we can preserve their ovum or embryo if they are married. For an unmarried woman, we cannot preserve a embryo.
Fine.
So we can preserve her ovum, and later on, if she gets married, we can use this ovum to form an embryo, and we can transplant it into her own uterus.
Fine.
Even surrogacy is accepted. One of the accepted indications for surrogacy also, if a woman has got her uterus and ovaries removed because of cancer. So they can have normal children. Okay. And next main thing is ovarian cancer. Before they use ovarian cancer, the disadvantage is most of the cancers they present at a later stage. It is a reverse of endometrial cancer.
Diagnose பண்றது
late ido. Most of them come in stage 3. So what happens is...
is it deadly, doctor, before that?
No, not death.
Life-threatening.
See, we can cancers one word I can tell is all cancers can be treated. Most of the cancers can be cured.
Fine.
Okay.
I understand.
You understand? So all cancers are treatable, but most are curable if they are diagnosed at an early stage. So what happens is this ovarian cancer, see, as it stages up to from stage 1, it goes to stage 2, it goes to stage 3, it goes to stage 4. The percentage of people who are getting cured comes down. Okay. If it is stage 1, 90% can be cured. Stage 2, 85%. Stage 3, 70%. Stage 4, it comes down to 30 to 40%. So that cure rate comes down. That even in advanced, for example, in ovarian cancer, now we have a latest treatment. I told you, right? Cytoreductive surgery and HIPEC, where we remove the entire tumor and give chemotherapy into the abdomen. Even for patients, we do one more treatment called PIPAC, in whom it will improve the quality of life. In a patient where we are not able to operate or remove the entire tumor, what we do is we give pressurized chemotherapy into the abdomen. It improves her quality of life. So, if the cancer is not curable, then we treat in such a way that it will improve her quality of life. The rest of the life, whatever she's living, we make sure that she's comfortable with that life.
Okay. Thank you so much,
thank you.
doctor. Thanks for the podcast. Like, நிறைய அந்த surgical விஷயங்களை பத்தி explain பண்ணீங்க. It's so helpful for us. Thank you.
Thank you.